So we'll move on now to biopsy conference, and I think that Behzad wanted to just do an introduction. Go ahead, Behzad.
Yeah, good morning. Thanks everybody for joining the conference today. So for the biopsy part, we're going to present 3 cases today, and the first one is going to be jointly presented by Drs. Thomas and Henrique Stickas. So I just pass it to David to show the slides and Dr. Thomas to start the clinical. Thank you.
Good morning, everybody. Please let me know if you are seeing the correct view.
It looks good.
Okay, it looks good. Very good. Thank you so much. Good morning, everybody, and welcome. I'll give the first few slides, introductory slides with the clinical background of this case to Dr. Bernadette Thomas.
Hi, can everybody hear me?
Yes.
Okay. Can I go ahead?
Yes, please.
Okay, thank you. I think you can advance to my first slide. Okay, thank you. So I'm very happy to get to present this case today. Especially grateful to the pathology department for talking to me through the case when I was early in evaluation. So this is the case of a 52-year-old gentleman with no significant past medical history who presented to an outside institution with complaint of fever, cough, malaise that had been going on for about 2 weeks. He went to an urgent care and gave his history and said that when he was coughing, he had noticed blood. At the urgent care evaluation, they were pretty worried about him and sent him straight to an emergency room. And in the ED, they did a standard workup involving chest X-ray and lab work. And he was admitted when they evaluated their workup. The chest X-ray showed what was read at the time to be multifocal pneumonia. And lab work was significant for a creatinine of 3.1. Again, he had no past medical history and didn't go to the doctor that much. And so there were no priors to that creatinine, but he had no prior known history of kidney disease or kidney issues. So he was admitted and started on broad spectrum antibiotics for what was thought to be pneumonia, ceftriaxone and azithromycin. And by the time he came to our institution, he was intubated. So this entire history was per chart review. Over the days in hospital at the outside institution, he got worse instead of better. He continued to have fevers, and he developed a worsening hypoxia over about 5 days in hospital. And so in response to this, his antibiotics were broadened to include cefepime and doxycycline. And continued lab work, continued observation showed that he was starting to develop a very significant anemia. I think you can do one more click. So on admission from urgent care to ED on April 1st, his hemoglobin was 7.8. And during that week of hospitalization, hemoglobin dropped to 6.7, dropped to 6.1. So he was transfused on 4.7 and then again on 4.8. And if you trend the hemoglobins, he came up to about the low 7s with those 2 transfusions and then dropped down again to the 6s. So he was transferred to their ICU and then intubated for worsening hypoxia. And with intubation, they also did a bronchoscopy, and the results of that were thought to be diffuse alveolar hemorrhage. And when they saw his pulmonary hemorrhage, then the care team at the hospital thought back to the fact that he had renal failure on admission. Now he was hemorrhaging, not responding to any antibiotics, and thought was this not pneumonia, and could this possibly be a pulmonary renal syndrome? So at that point, they transferred him to Northwest Hospital out of concern for pulmonary renal syndrome. And if it was possibly pulmonary renal, would he need plasmapheresis, which they weren't able to provide at their institution. So before transferring him, they did give him solumedrol, and they gave him 500 milligrams. And then the next day they gave him a gram and transferred him. So just for completeness, again, his past medical history was fairly negative. Family history was negative and no major surgeries. Did have reported allergy to nuts, and he was married. No children, no toxic drug habits. So he came to Northwest Hospital and went straight to the ICU, intubated, requiring 100% FiO2 and mild pressors, and was oliguric. So the day that he was admitted, plasmapheresis was initiated just because of how rapidly worsening his clinical case was. And then a glomerular workup was sent from our institution, and had also been sent from the prior institution, but it was the day of transfer. So we didn't really have any glomerular specific labs to work off of at the time. So on the day of admission to our hospital, his basic metabolic panel showed a sodium of 142, potassium of 4.9, chloride of 106, bicarbonate of 20, glucose of 180, and BUN to creatinine 81, and a creatinine of 4.6. CBC showed a white count of 24, and this was him having gotten 2 pretty hefty doses of steroid. Hemoglobin of 8.7, crit of 29, platelets of 517, and a UA positive for protein, positive for blood. And so then we started to get some labs back over the next day. His ANA was negative, and complements resulted pretty quickly. The C3 of 121, a C4 of 14. His anti-GBM from the outside institution resulted, and then ours resulted as 82. And interestingly, his ANCA results were also positive, with a cytoplasmic ANCA ratio of 1 to 160. So we continued to plasmapherese him for 2 weeks because he had diffuse alveolar hemorrhage at outside institution. And when we repeated his bronchoscopy after high-dose steroids, he was still hemorrhaging. So 2 days after he arrived at our institution, we administered a gram of Cytoxan, and also started dialysis to assist in volume management and for clearance. We continued the high-dose steroids, and then repeated bronchoscopy at the end of the first week that he was admitted to us, which still showed diffuse alveolar hemorrhage. And so he stayed pretty sick for 2 weeks after getting to our hospital. And this was with daily plasmapheresis, QOD dialysis, high-dose steroids, and loaded with Cytoxan 2 days after arrival, and intermittent blood transfusions as needed. We wanted to biopsy him, of course, pretty soon after he got to the hospital, but all of the services involved just thought he was too sick, and it was too high risk. And the serologies, were guiding our management at that point. And so we thought it wouldn't really add anything, and the risk benefit wasn't worth it during those first 2 weeks. So he did eventually start to respond, and FiO2 requirements started to go down, and he started to make urine, though he never cleared, and so he continued to need pretty frequent dialysis. And we were able to extubate him towards the end of April. 2 weeks after the first dose of Cytoxan, he was redosed with another gram. And then he was reintubated for recurrent respiratory decompensation. And with that reintubation on the 26th, he was again bronched, again showing diffuse alveolar hemorrhage. And that was around that time I called Dr. Najafi and we proceeded with renal biopsy. And then managed to extubate him. And at the beginning of May, nephrology, rheumatology, ICU medicine, hospitalist medicine, all kind of did a huddle and thought that it would be worth it to add, to layer Rituxan onto treatment, given the fact that this by serologies looked like a double positive, pulmonary renal disease with anti-GBM being positive, but also with his ANCA being positive, just being unclear about which disease was being more predominant in driving the boat. And with his optimized anti-GBM therapy and him continuing to have this pulmonary hemorrhage, continued reintubations, we thought, would it be, prudent to add Rituxan on board, just in case this was a disease that was favoring a more of an aggressive ANCA versus the anti-GBM. After a lot of deliberation, we ended up dosing him for Rituxan.
Thank you, Dr. Thomas. We have the findings of the biopsy that was performed. This is an attempt to show you the sample. There were some fragments. There was a significant portion of the biopsy comprised of medulla only, and a cortex that initially in our routine sections only demonstrated about 3 glomeruli. So we decided to submit deeper levels, to which we obtained about to 10 glomeruli. Majority of these glomeruli they were involved by crescents and or evidence of some progression to chronicity with fibrocellular crescents. You can identify that in these glomerulus over here in this area that is segmentally involved by this lesion, and there's a center that is starting to organize. There's a globally sclerosed glomerulus, and then this third glomerulus here that we have another segmental portion involved by crescents. Now, this is happening in the background of acute tubular injury that also is secondary to this active glomerulonephritis. Now, we see a little bit of a higher power view of these single glomerulus and see the organization of these cellular crescents here, the proliferation of epithelial cells that is involved in segmentally as glomerulus. And you can see that is starting to organize in this area. We have another picture of another glomerulus, similar portion. There's some inflammatory cells here. There's some apoptotic debris within the crescent. This is more of a cellular type crescent. And if you can identify in this tubule, there is this material that corresponds to red blood cells, or within, this is a cast of red blood cells, and they have been losing some of its pigment, and that is very suggestive that this is a real cast and it's just not related to the procedure, and it has been there for quite a few days. And in the background of acute tubular injury as well. And this is the single glomerulus just seen by PAS. Sometimes it helps to brings us a different point of view and same kind of features that we are seeing on this. And also to note that the remaining uninvolved glomerular segment is not showing significant pathologic abnormalities. The background parenchyma, as I mentioned, had acute tubular injury and some secondary interstitial inflammation secondary to the glomerulonephritis, as well as red blood cell cast. So by immunofluorescence microscopy, this was very interesting. It has this modest linear staining for IgG, which can identify it, for example, in these areas that is not involving all the segments, is modest the intensity is not strong, and as well as not highlighting all the capillary loops. It's just segmentally involved in this. There was no tubular basement membrane. I will mention why was this important. It was probably one tubular basement membrane that was very weakly highlighted with IgG as well. And this is another glomerulus with very modest segmental staining that is linear and smooth. And as expected with these features of activity, we have this segmental accentuation of the urinary space, and where we can see this area that is suggestive of cell proliferation and is highlighted by fibrin and fibrinogen stain. Now, these are the corresponding pictures from the slide stained with H&E that is from the frozen tissue submitted for immunofluorescence microscopy. And we see a similar picture that we saw in the sample submitted for light microscopy. Just to summarize, what we saw is staining that is very modest, it is linear, only up to 2+ in some areas, most of it 1+, and weak and very focal tubular basement membrane staining in only one tubular basement membrane section. This modest staining, however, is staining for both kappa and lambda. This is not a monoclonal process, and as expected, the intratubular cast and tubular reabsorption droplets are also staining for both kappa and lambda. We did not see significant glomerular staining for all other immune reactants, including IgA or IgM or C3 or C1q. And there was no significant interstitial or vascular staining. So by electron microscopy, the findings on the uninvolved glomeruli and on the uninvolved segments was pretty unremarkable. The mesangial regions are devoid of any immune complex, and basement membranes were of normal thickness, architecture, endothelial cells are flat with preservation of their normal and usual fenestrations, podocytes looking good with the preserved podocyte food processes. So pretty unremarkable from the electron microscopy point of view. At this point, based on the clinical history and these, I think it's pretty clear that this is a complex case that has features of both pauci-immune type glomerulonephritis, and by immunofluorescence microscopy, we also have features of anti-GBM, as Dr. Thomas emphasized before. And the reason, or the most important point on this biopsy, was to identify what is the most likely feature driving or likely driving this clinical presentation. And that is somewhat difficult to identify by morphology, but we are able to suggest certain things. For example, we have a diffusely crescentic and segmentally necrotizing GN with features that are combined for anti-GBM and PR3 ANCA. And with this crescentic and segmental necrotizing glomerulonephritis, we have both features of activity and chronicity. And number 2, widespread acute tubular injury and focal active interstitial nephritis that is secondary to the active glomerulonephritis. As well, the chronicity of the parenchyma is it was very mild. As you could see in the low power picture that I presented as a collage, it was very well preserved parenchyma overall. Now, this crescents involved about 50% of the sample glomeruli. Most of the crescent formation was of fibrocellular nature, so has a partial cellular component, and this is important because suggestive of subacute nature, as you mentioned that this biopsy was not performed until about a month after or 3 weeks after the first clinical presentation. So that is consistent with the clinical history. And secondary to that, up to a third of the glomeruli had global glomerulosclerosis. That may be or may not be completely related to this process. And last but not least, the modest linear staining for polyclonal IgG consistent with anti-GBM. However, we will discuss that the modest intensity of this staining, it is likely reflecting the low titers of anti-GBM of this case. And at the time of the biopsy, as far as we understand, the titers were negative at the time of the biopsy, and that likely is reflected by the modest staining of IgG. Now, the features that support a concurrent ANCA involve a segmental involvement of the glomeruli by the active lesions, different stages of activity and chronicity. We have globally sclerosed glomeruli, fibrocellular crescents, we have more cellular crescents, and segmental necrosis. And then from the clinical point of view, intermittent partial improvement followed by relapse. And that was accompanied by increased serum PR3 ANCA, which is not a usual presentation of anti-GBM, which I will explain in a couple of minutes. So, and this is a diffusive crescentic, most important just to summarize that the big text, the combined features of anti-GBM and PR3 ANCA and widespread acute tubular injury. So the natural formation of a crescent, just to give us a quick reminder, is based on the formation of crescents indicate rupture of glomerular capillaries with leakage of plasma and the hyperplasia of parietal epithelial cells that leads to a single nephron impairment that will present as a clinical renal failure. Now there's a mixture of cells, fibrin, and fibrous matrix. Depending on the percentage of these components, they will have cellular, a fibrocellular, or a fibrous crescent. Not all the crescents will evolve to fibrous crescents. Some of them may result, depending, a lot of these will depend on the integrity of Bowman's capsule and the cellular composition of the crescent. So it's important to know this when you receive a report from pathology to discuss this finding of how is the integrity of Bowman's capsule on the sample glomeruli, and also the status of the crescents in what stage of development. Now, crescent is somewhat, crescent formation is somewhat non-specific. It's just the final response to several different entities that can lead to the end vascular necrosis and rupture of the GBM with, as I mentioned, plasma leakage and activation of coagulation factors within Bowman's space and other downstream changes. And this can happen in immune complex GN or ANCA-associated vasculitis, anti-GBM disease, C3 glomerulonephritis, or even IgA nephropathy and other entities. And important to see is in both anti-GBM and ANCA-associated vasculitis is the GBM breaks with necrosis and crescents as a common feature. Now we have in anti-GBM usually is more widespread, involving most glomeruli. And in ANCA, this may be focal, but there's a little bit of variation. The areas of necrosis may be small and segmental, may also be extensive with large circumferential crescents, but they usually tend to be segmental and focal. The uninvolved segments do not show changes in anti-GBM disease, and that's usually the same for ANCA-associated vasculitis. Now, in anti-GBM disease, the crescents, in talking about pure anti-GBM disease without ANCA-associated, the crescents tend to have the same stage of activity and chronicity. And this kind of reflects the one-hit nature of the clinical presentation. Whereas in ANCA-associated vasculitis, we have more variability in the crescent development. We see this in this case, in which we have some areas of more cellular and predominantly fibrocellular, and we have those kind of variable features. Now, in anti-GBM disease, we don't see extraglomerular vasculitis, whereas in ANCA-associated vasculitis, we may see vasculitis involving intralobular arteries or other arteries present in the sample, and also medullary angiitis. Just to be clear, we did not see extraglomerular vasculitis in our case. And by immunofluorescence, the main difference will be the linear GBM staining for polyclonal IgG in case of anti-GBM. Occasionally, they may have cross-reaction and also show TBM, and that's why I mentioned that. We did see a very weak infocal TBM staining. And for ANCA-associated vasculitis, we have no significant immune complex deposition, or it may be very weak. So this has been reported since the 80s. This is a report from 1989. It's a sequential development of systemic vasculitis with ANCA, complicated anti-glomerular basement membrane disease. And this is not so uncommon. It happens in about 1/4 to 1/3 of patients with anti-GBM antibodies and about 5% of patients with ANCA. Now, this is a very interesting paper. The coexistence of anti-GBM antibodies and MPO-ANCA is this is basically telling us that double positives and anti-GBM have a different prognosis that pure MPO-ANCA. This is a paper from 2005. So it raises a lot of questions if this anti-GBM disease is really a spectrum. We are talking about classical anti-GBM, and then we have, like our case, double positive anti-GBM, or people who has a linear IgG with a preserved renal function, or other variations of the clinical phenotype. So to just almost finalize, because we are running out of time for the next couple of cases, I just want to mention that in this paper from 2017, the double seropositive ANCA and anti-GBM antibodies have different renal survival, frequency of relapse, and outcomes compared to single seropositive patients. This is a study from Europe, and we have a true hybrid disease phenotype, just like our patient. Some they tend to present with early features that look like anti-GBM, but they have relapse as ANCA vasculitis. So, and we can see that they form a third group with different renal survival. As you can see in this Kaplan-Meier curve, the solid black line is the double positive, whereas the two extremes, they have better survival for ANCA vasculitis and worse survival for pure anti-GBM. So they stand approximately in between those two groups. And they tend to show this more, these are the double positive, the dark gray. They tend to show more like ANCA vasculitis. Instead, the pure anti-GBM shows the classic bimodal distribution, and peak early in life and then peak later in life, whereas double positive in this regard tend to present in elderly people. And also they show that they have a little bit less people with dialysis, and they tend to move to dialysis free on the follow-up, whereas the people who are single positive, they tend to stay in the group of dialysis dependence. And again, the survival curves are very different for the three different groups. So takeaway points, we don't know how the double positive anti-GBM disease works. The hypothesis is that the vasculitis process exposes antigens that has been previously known exposed, and that's the reason why there's anti-GBM. That has not been proven. Are they a distinct clinical phenotype? Another takeaway, these are very rare diseases anyway, and even more rare when they're combined. And the difficulty in the pathology characterization, and because of the papers we have, they have different exclusion criteria and different definitions of disease by pathology. So that's what I have for this case. Sorry, I went over 2 minutes.
Thank you, David. Thank you, Dr. Thomas. Dr. Thomas, do you have any follow-up for this case that you would like to share?
Yeah, I talked to you and also talked to Ashley when we were continuing to have difficulty with recurrent alveolar hemorrhage. And the main question that I had at that time in managing the case was whether we needed to think about layering Rituxan on board. And this is after he had already gotten 2 weeks worth of Cytoxan. And one of the things we discussed is whether to dry him out more and just to prevent pulmonary edema from being a factor clinically that was preventing him from really being able to respond to the therapy and continuing to bleed. So we started to ultrafiltrate him much more aggressively. And he had been making about 1 liter of urine a day at that point, and that stopped, but he clinically improved. And I really can't say what contributed. It might have been the Cytoxan finally hitting full effect in him. The steroids and plasmapheresis mainly stabilized him only, but really after more aggressive ultrafiltration and time, he started to improve. I'm very happy to report he's on the floor. He's been extubated for several days. He's feeling stronger. He's still dialysis dependent, but I really do think it's because we really dried him out. And he's about as stable from the hemodynamic perspective, from his anemia perspective, that he's been the entire hospitalization. So he had a high, we all thought that he had a very high likelihood of dying from this. So I'm very grateful to everybody on this call for their assistance and weigh-in. And I think the biopsy was helpful in letting us know that there was definitely a significant presence of ANCA as well, and that it was worth it to consider Rituxan. I think time will tell whether we made our right decisions at the right time.
Just a quick comment. I'm not convinced that these double positives are a homogeneous group. I think some of them actually just act more like anti-GBM disease that happen to have an ANCA and actually do quite poorly. Whereas others behave more like an ANCA disease and happen to have an anti-GBM titer. So I'm always concerned about the papers that sort of show this middle ground, that they sort of on average do slightly better than one and slightly worse than the other. I'm not sure that it's just a single group of patients.
Yeah, well, I think one of the graphs that David showed was, reflecting the same point, and I agree with you that there is a spectrum of pathogenicity of different antibodies of anti-GBM as well. So the spectrum, there is a spectrum. Obviously, some of them are more behaving like anti-GBM, some of them more like ANCA.
Yeah, I think there was a question about the treatment plan. We're going to finish the Rituxan course and just kind of monitor how he's doing. We're still working rheumatology and nephrology together on thinking through his maintenance.
Also on light, he had like lesions in different stages of development. I mean, it goes more with the ANCA as opposed to anti-GBM, where it's like either cellular or fibrous crescents.
There were evolving fibrocellular crescents towards becoming fibrous, but we had a couple of crescents that they were more towards the cellular and with a very little fibrocellular component. Most of them were fibrocellular. We also had about 1/3 of the glomerular globulus sclerosed. Hard to tell what was the background, but one could imagine that maybe this patient has had and slowly progressive ANCA process in the background, creating those globally sclerotic glomeruli. Okay, if there is no further questions for Dr. Thomas, maybe we can move to the next case. Thank you very much, Dr. Thomas.
Thank you.
Appreciate it.
I think we're next, David. Does everyone see the presentation mode?
Yeah.
Looks good.
Great.
All right. So this is a case of an outpatient I had recently. So an 80-year-old woman who presented for new onset CKD, edema and proteinuria. She had a past medical history of a cabbage in 2007, hypertension, gout. She had a trauma to her left foot years prior and was diagnosed with chronic left foot osteomyelitis on lifelong antibiotic suppression, though not really clinically active, and there was some debate about whether to stop the antibiotics. Hyperlipidemia and pre-diabetes with A1Cs generally in the low 6s, 6.1, 6.2 for some years. She wasn't really having any particular symptoms other than a chronic sense of urinary hesitancy, but no shortness of breath, no constitutional symptoms, no other urinary symptoms. She wasn't using NSAIDs or any unusual over-the-counter medications. In terms of her medications, she was on allopurinol for her gout, amlodipine for blood pressure, Augmentin as her osteomyelitis suppression, baby aspirin, atorvastatin, some vitamins, losartan, and metoprolol. In her family, no history of renal diseases as far as she was aware. Social history, she had no toxic habits, never smoked, no alcohol use, no recreational drugs. She was from Cambodia, had worked for a paper there actually. Could do next slide.
Yeah, I'm trying to. There we go.
So her blood pressure was high at 148/63. She weighed 51.5 kilos, so not obese by any means. On exam, she did have venous stasis changes and some brawny skin discoloration with some edema in the bilateral lower extremities. I took a look at her foot. Honestly, I didn't see anything. I didn't see anything unusual. Otherwise, the exam was unremarkable. No other signs of hypervolemia except the leg edema. Her labs were notable for a creatinine of 1.19. Her baseline creatinine was 0.8, and it had been 0.8 up until 1 year prior. When the creatinine started rising. She had no clinical events in that interim. Otherwise, labs were notable for a hemoglobin of 9.6, hematocrit 29. On her UA, she did have protein. It was a urine protein creatinine ratio of 2.1. There were no prior ratios or proteinuria quantification, so I didn't know what the chronicity of that was. And our UA also was notable for a small amount of RBCs, which that was new compared to prior UAs. So I did a microscopy, but they appeared isomorphic. So I did some serological workup. Monoclonal studies were unremarkable. Her kappa lambda was 2.05, but with her reduced GFR, didn't get too concerned about it. Rheumatoid factor, CCP antibodies were negative. ANA was positive, 1 to 80 densifying speckled, but all the reflex studies were negative. So dsDNA, anti-Smith, SSA, SSB were all negative. ANCA serologies were negative. No infectious issues, hepatitis, HIV. I checked quantiferon just in case, because she's from Cambodia. All of that was negative. Complements were all within normal limits. So I started treating her with an ACE inhibitor, and I wasn't really thinking to biopsy her at age 80. I figured that maybe there was some chronicity with blood pressure or whatnot that had kind of progressed, but wanted to keep a close eye on her just because it seemed to be a little bit more rapid. And then when she came back a couple months later, she was actually having worsening edema. Now she was complaining of shortness of breath and orthopnea, and her blood pressure had worsened despite the her blood pressure meds and having been stable up to the 160s. I repeated her urine protein creatinine ratio. It had become nephrotic range at 4. Her albumin had gone down to 2.9. Her creatinine was creeping up to 1.4. At this point, I checked a PLA2R, which was negative. And after a lot of discussion, given her age, and the question was, how aggressive are we going to be? But we ultimately decided that given how rapid this was evolving and how she was feeling, that we were going to do a biopsy and look if there was a reversible cause we could treat.
Great. So I'm sure that this is a pretty straightforward case. Everyone probably knows what it is. So you could put your differentials in the chat if you want. Are there any questions, additional questions for David about the clinical history? No questions? Okay, we got one, seronegative ANCA-vasculitis. Okay. Allopurinol induced. Great, very specific, okay. Yeah, long history of osteomyelitis, gout, treated with allopurinol. I guess, PLA2R is negative, but we all know there's a lot of other forms of membranous nephropathy that could be responsible for the proteinuria, and then other causes of proteinuria, right? So AA amyloid is another one. We're getting a lot. And thanks to Ball for his contributions. So why don't we go ahead and look at the biopsy? So this is a low power view of the cortex that we got. You can see there's a small artery here that doesn't show a lot of intimal sclerosis, but we do have some sclerotic glomeruli. And you can notice there's a lot of changes within the glomeruli that you can even appreciate at low power. There's some patchy tubular atrophy and interstitial fibrosis. So there's a mild degree of chronic injury here. But I think what we really want to do is look more closely at the glomeruli. And so here's a glomerulus over here that has some ischemic type changes with a little bit of increase in mesangium. And the one over here shows some marked expansion of the mesangium. So this is nodular mesangial sclerosis. And this is what we would term a Kimmel-Steele-Wilson nodule. As well. And there's some vascular disease, and we'll look at that in more detail. Here's a PAS stain that can accentuate some of the global sclerosis, as well as hyalinosis in some of the vessels, and the mesangial sclerosis that's nodular in many of these glomeruli. Another glomerulus with PAS stain that shows nodular mesangial sclerosis, and then more diffuse with early nodule formation elsewhere. The peripheral capillary loops don't show a lot of changes. There's some segmental abnormalities, but it looks more like a mesangial sclerosis process with these prominent nodules, some of them forming these vascular channels within the mesangium. So this really looks like diabetic nephropathy. And this is another higher power view from a Jones stain of a glomerulus. And in addition to the nodular mesangial sclerosis, we see some prominent mesangial lysis. So we see areas where there's really no distinction between where the mesangium ends and the capillary loop begins. And we see blood cells sort of intermingling with areas of expanded mesangium, as well as in what we imagine as the remnants of the capillary loop here. Again, over in this glomerulus, we see some segments where the capillary lumina are preserved, but then others where they're completely obscured by this process of mesangial lysis. Again, everything I'm describing is features that we see in diabetic nephropathy. Another glomerulus, again, beautiful nodular mesangial sclerosis, some mesangial lysis at the ends of this, a little bit of this neovascularization as well at the efferent arteriole. Again, that's a feature that's, all of these are are prominent features most commonly seen in diabetic nephropathy. And then a little bit of arteriolar hyalinosis. It's variable. We can see a small arteriole here that has really no significant changes, and then some more notable hyalinosis here. So not as much microvascular hyalinosis as we can frequently see in diabetic nephropathy, but there is some that's present. And here's another section showing some of the arterioles that show a little bit more hyalinosis that's detectable, but not severe in most instances. So there was no findings on IF, and there was nothing on electron. There was no sample for electron microscopy or no diagnostic glomeruli, and so we're left with light microscopy and immunofluorescence microscopy to come up with this diagnosis. And the diagnosis that I gave this was idiopathic nodular glomerulosclerosis. There's also some chronic injury of focal global glomerulosclerosis and tubular atrophy and interstitial fibrosis, and then this moderate arteriosclerosis and focally severe arteriolar hyalinosis. And so in the comment, it basically, this looks a lot like diabetic nephropathy. Are you sure this patient doesn't have diabetes? And David, did a lot of work to evaluate that, and the patient doesn't, had the pre-diabetes, had some, mildly elevated hemoglobin A1C levels in the past, but that's really about it. So no clinical history of diabetes. And so changes that look like diabetic nephropathy in the absence of a diagnosis of diabetes are termed idiopathic nodular glomerulosclerosis. So what is that? Well, it was actually first described by our own Dr. Charles Alpers, and he termed it at that time idiopathic lobular glomerulonephritis or nodular mesangial sclerosis. And basically, the conclusion was exactly what I've just mentioned. It looks like diabetic nephropathy, but the patients aren't diabetic. A subsequent study that I think is very prominent in our in how we think about this disease was done by the Columbia group, and they looked at patients with idiopathic nodular glomerulosclerosis and found that they were, compared to patients that were biopsied for diabetic nephropathy, the idiopathic nodular glomerulosclerosis patients tend to be older, hypertensive, and in this instance, almost everyone was hypertensive. They're also smokers, so they're just a 91%, in their study were smokers. They had hypercholesteremia, and they also had some extrarenal vascular disease. So in this study, I think has sort of formed our bias towards thinking that, well, people with idiopathic nodular glomerulosclerosis are essentially smokers with hypertension. And we know that this patient had hypertension, but she didn't smoke, and so that didn't quite fit the mold here. And I think the smoking, one of the things that really drew a lot of attention was when they compared the progression to end-stage renal disease in patients. And the ones that continued to smoke, they essentially, within about a 2-year period, they went to end-stage renal disease, whereas the individuals that never smoked or stopped smoking had preserved renal function. So this high incidence of smokers, plus this idea that, hey, we got a great intervention, we can just tell people to quit smoking and we can preserve their kidneys, has really kept this as a prominent feature in our conceptualization of nodular glomerulosclerosis and the pathophysiology of this disease. Well, there's a new study recently looking at idiopathic nodular glomerulosclerosis and comparing it to diabetic nephropathy, and this is a KPMP project that was led by Michael Eden at Indiana University, and they looked at both clinical and histopathologic findings as well as looking at gene expression studies. And they started out looking at all of their biopsies from almost like a 20-year period, over 6,000 biopsies, and then they found a bunch of nodular ones. Of those, most of them were diabetic biopsies, but then they had a fair number that were still nodular without confirmed diabetes, and then they went down to narrow these into ones that were truly idiopathic. And of the 229, they found that 51 were really alternative diagnoses to some other type of glomerulonephritis in many instances. And then about 180 of these were still up for grabs. Of those, 130 were actually excluded, and they ended up with 48 that were really what they've termed idiopathic nodular glomerulosclerosis. And I thought what was interesting, if you look at these, there's the minority of these are really not enough clinical data or some rare disease processes. And then the majority of the ones that were excluded is they actually found that there was clinical evidence of diabetes in chart reviews. So a lot of the patients that they were calling, that they might have called, or we might call idiopathic nodular glomerulosclerosis, when there was a more in-depth chart review, they said, oh, there's actually clinical evidence of diabetes mellitus. And what does that mean? Well, they were basically looking at, did they have diabetes mellitus in their electronic medical record? Did they have an A1C over 6.5%? Any fasting blood glucose greater than 126? Random glucose is any two random greater than 200? And then any prior use of anti-diabetic medication. So looking at these exclusion criteria, I think that the biopsy that we showed today would still probably fall into their idiopathic nodular glomerulosclerosis category, because the patient had, some of these things, but I don't think these criteria these exclusion criteria were met for that patient, for our patient. So what did they find? They basically look a lot alike. And as I said, these are very, very hard to distinguish. They reproduce some of the findings that have been described earlier, basically that one difference is there's the arteriolosclerosis, or the arteriolar hyalinosis is not as severe in the ING patients compared to the diabetic nephropathy patients. And that there's also a little bit more of FSGS in the ING patients than the diabetic nephropathy patients. And then really, again, they confirmed many of the clinical features. They're older, they tend to have less proteinuria, they tend to have more hypertension, but there's a lot of hypertension in both, so substantial overlap. And they also tend to smoke more, except here, notice that we're not looking at 91% smoking, we're actually looking at 66% smoking. So this is, suggesting that, the smoking history is not as prevalent in other cohorts, even though it is a notable increase compared to diabetic nephropathy. And then they tend to be a little leaner, not lean, but leaner than the diabetic nephropathy patients. So the next thing, and the thing that they wanted to do is, well, let's look at the molecular detail of this. So they did laser capture microdissection on the biopsies from patients. They're able to find 5 ING patients, and then about 18 diabetic nephropathy patients, and then 9 controls. And they say, okay, let's look at the molecular features by doing laser capture microdissection on the frozen samples from these patients and see whether or not we can find any pathologic differences. And I think, one of the impressions you can see here is that when they did hierarchical clustering of the reference cases in blue, the diabetic cases in green, and the ING cases in yellow, that they don't really segregate. So they're really, fairly well intermixed. There's a group of the references that lump together, but then, and a group here and here, but there's no real pattern. And same thing with the principal component analysis. There's one clustering of 6 of the reference cases, which may be the ones that came from partial nephrectomies, but everything else is sort of splayed around and not really grouping together. Despite that, they did find some gene expression differences, and I won't go into this in detail, but if you look at reference genes, there were 458 genes that were difference between ING and reference, but if you compared diabetic nephropathy and idiopathic nodular glomerulosclerosis, that dropped down significantly. So there's only 92 differentially expressed genes using RNA-seq. And so very few genes, and then they did some pathway analysis to do that, but not a lot. So very few differences, but there were some differences. So, summary, they did identify multiple differences. The small number may suggest that these entities really have some similar pathophysiology, But one caveat is that the small number of differentially expressed genes that they found in their study may really be due to some of the technical limitations. And what are some of those? They actually used their clinical biopsies. So the clinical biopsies were used for the RNA studies, and these are ones that, just like the ones that you procure, you put them into transport medium and they sit around for who knows how long, and then they're frozen and stored in the clinical lab for, and sometimes years before they were used in the study. So how good are those samples for RNA studies? I think that that's something that we have to consider. And then in addition, there's a lot of variation, as you could see. There was not a really good way to segregate these diseases when they did clustering. And some of that might be just due to the fact that if there is a lot of clinical variation, the small number of cases is not going to be adequate or powered to be able to identify those differences. Nonetheless, they said, well, there's overlapping but distinct transcriptional profiles. So they're suggesting that there may be some pathophysiology that differs between these two entities. So I just wanted to present another study very briefly that suggests, well, there might be some similarities. And this is a study that looked at patients with ING and actually noted that there was a fair amount of impaired glucose metabolism in these patients. And so they identified 17 patients in their biopsy archives that had this diagnosis. None of the patients had diabetes, but they noted that some had intermittently elevated blood glucose and borderline high hemoglobin A1C levels. And so you're looking at that 7 out of 9 that had both of these measurements, had either an elevated blood glucose, and or an elevated hemoglobin A1C, still in the low range, not sufficient for a diagnosis of diabetes. And here they suggest that, well, maybe insulin resistance and impaired glucose tolerance is a central part of the pathogenesis of idiopathic nodular glomerulosclerosis, similar to what we have proposed for the pathophysiology of diabetic nephropathy. And then so, just as a summary, I thought, well, maybe we have a bunch of contributing factors when we think of nodular glomerulosclerosis, that there's insulin resistance and impaired glucose tolerance. There might be environmental factors, maybe smoking. And there also appear to be genetic factors, and these are coming out of larger GWAS studies. So there can be a combination of environment and genes that are contributing to the susceptibility. If you look at diabetes, diabetic nephropathy, we suggest that the insulin resistance and impaired glucose intolerance is really a overriding factor for this. And then maybe with idiopathic nodular glomerulosclerosis, that the environmental and genetic factors are also there, but there may also be some role for impaired glucose tolerance. So in the end, what does our patient have? Is this really diabetic nephropathy, or a version of that that's way off on one end of the spectrum, or is it truly a distinct entity of idiopathic diabetic nodular glomerulosclerosis or idiopathic nodular glomerulosclerosis? What additional diagnostic workup is needed in this case, and how really would this actually impact treatment decisions? So I'll turn it back to David and the audience for questions and comments.
Yeah, so I'll just say, so I had my first follow-up visit with her since the biopsy, and only thing I've done so far, I've ordered an oral glucose tolerance test. So we'll see what that shows. And I'm just kind of working really hard on her blood pressure control. She's already on a maximum ARB, so kind of toying with an SGLT2 for proteinuria and potentially helping the blood pressure a little bit, and just kind of focusing on blood pressure because she doesn't smoke. So until we get kind of a better sense of her glucose tolerance, looks like high blood pressure is her biggest modifiable risk factor. So yeah.
So there's a question about saturated O2
Sorry, you mean just like if she's hypoxic, or?
It's just SaO2 question mark.
There's an association with idiopathic glomerulosclerosis with cystic fibrosis and possibly with hypoxic conditions. I'm just wondering if she has any evidence of hypoxia.
No, not. I mean, I haven't looked too closely, but just her oxygen sats on her clinic visits have been normal.
All right. Any closing comments, Kelly, or is that wraps up your?
Well, no, I think that's closing. I think, basically, I think we probably need to learn more about idiopathic nodular glomerulosclerosis and the pathophysiology of it, and that might help. It's a rare disease, and again, it's a difficult disease to really, I think, characterize clinically and pathologically because of its rarity.
All right. Well, thanks to everyone for their participation this morning, and we'll close at this time. Everyone have a good weekend. We'll see you next week.
Thank you very much.